Thank you, AIOS, for giving me this opportunity. I'll be speaking on the management of corneal perforation and decimeter seal by different techniques again, so kindly bear with me. So, corneal perforation is different from laceration because of tissue loss, making the management more complex and challenging. In most of the cases, the diagnosis is pretty obvious, but sometimes in occult perforation, we need to take help of Siedel's test to confirm the diagnosis. There are various predisposing factors which may lead to corneal perforations. We all know those. And while treating these cases, we have two goals. First, we will have to treat the underlying cause, and second is the reconstitution of the globe. So while dealing the underlying cause, so we should always use preservative-free topical drugs as much as we can. If we know the cause is infectious, we can start fortified drugs, and it's also good to give systemic antimicrobial coverage. If the underlying cause is dry eye, then we should, whatever surgery we are planning to do, we should plug the puncta at the time of surgery. To promote corneal healing, oral doxycycline and vitamin C are really recommended, and they are very helpful. And if we are dealing with autoimmune association, like in peripheral perforation, we should take rheumatologist in the loop because we want to treat the patient as a whole. So various treatment options we have to deal with these cases. Number one, let's go with TABCL in 1 millimeter of perforation. So two things we should always remember. First, we should denude the epithelium because cyanoacrylate won't stick to epithelium. And second, we should dry the surface because we want slow solidification of the glue. Then just a tiny drop of cyanoacrylate will do, and then wait for, let it dry and then place your BCL, and that's it. So this was the case in which I have done TABCL, and you can see within a period of 1 month, the eye became absolutely quiet. But because patient was having dense cataract, so I had to do triple procedure for visual rehabilitation. Another good, technique is Tenon's patch grafting, and any anterior segment surgeon can do this because we all see these cases of perforated corneal ulcer in day-to-day practice. So usually I take Tenon's patch graft from the superior temporal quadrant, and here I am taking it. And with the help of fibrin glue, after washing it thoroughly, you just plug the defect, and I put overlay sutures. In small cases, I put 2 overlay sutures. If the perforation is 3 or 4 millimeter, we usually put 3 overlay suture in the infinity pattern. And you can see the suture which is going in sclera. I have done selective peritomy over there because we should never put sutures over the conjunctiva. They tend to get loose over the time. So we have done so many Tenon's patch grafting, and patients, they really do well with this. Another multi-layer amniotic membrane transplantation, usually we reserve for the cases where ocular surface is not very healthy. Like this case, patient was having total LSCD and Sherman's was 0. And she was having 6 into 8 millimeter persistent epithelial defect. So we decided to go ahead with a multi-layer amniotic membrane transplantation with the help of fibrin glue. And because this was large, so I put 8 interrupted sutures. Otherwise, in most of the cases, I put 4 interrupted sutures to make it stay over there. Then I put a large, graft of amniotic membrane covering the whole of the cornea, and put, running sutures all around. And in every case of, amniotic membrane transplantation, I always do tarsorrhaphy as well. So tarsorrhaphy always helps to amniotic membrane to stay longer. And this is the result of this case. You can see the persistent epithelial defect. It was completely healed within a period of 18 days, and patient was very comfortable. If the perforation is associated with area of tissue necrosis, then you will have to remove the whole area, and then you will have to do you will have to replace this with cornea itself. Like in this case, I'm removing it all, and I'm using the same derma punch for the donor as well as for the recipient. I don't take any disparity, and in most of the cases, I put 8 suture up to 5 millimeter of full thickness corneal patch graft, and they do well. So there are some of my cases in which I have done full thickness corneal patch grafts. But one thing we should always remember that in these cases, on a later date, we will have to do cataract surgery. So we should always try to save iris as much as we can, because for an uneventful cataract surgery, our pupil should be round and circular. Many crescent shape patch grafts we have done to save the eyes in cases of peripheral perforation, and sometimes, like this case, he was having this eye only, and in that eye he had this peripheral perforation, and we saved this eye, and he is having at least ambulatory vision for the life. This was also one very challenging case. This patient had electric burn, and in bilaterally he developed corneal ulcer, and he was referred to me with this 3 into 3 millimeter descemetocele. So, and you can see preoperatively the thickness of cornea was 100 micron. So I decided to do, in this case, lamellar corneal patch graft. And but in lamellar corneal patch graft, we will have to first prepare pockets 360 degree with crescent knife to avoid perforation while we are suturing. So here I am done with my pockets. Then I did lamellar dissection of the donor cornea, and with this 3 millimeter derma punch, I am taking my lamellar corneal patch graft, and then I just place it over the defect and sutured it. This was the immediate post-op pic just after surgery, and then after a few months of follow-up, you can see the contour has become pretty normal, and you can see this is the host cornea, and graft is snugly and nicely fit into the defect. This is the recent pic of the patient who came after 1 year of follow-up in April, and he was having 6/9 vision in this eye. Lastly, with the large central perforation or perforation with large area of tissue necrosis, we have no choice. We will have to go ahead with TPK. So that's all I have. Thank you.
I think this is a wonderful talk.
Very good, very nice, very beautiful surgery videos, and very real time. It feels very encouraging, very nice. I think everybody
COVID,
has.
at least, just sorry to interrupt you. COVID gave us some of the new breakthrough in our mind, especially being a cornea person. We are not getting the tissue.
Yes.
Specifically, we are initially it was very difficult. Then the concept of the tenon patch graft come, and everybody trying to modify the things. Most of the time we have seen this in Bangladeshi patient over in Calcutta I'm from. So see, they don't have the tissue, actually it's predominantly Muslim country. So they have the Ganda sunflower, very nicely Ganda sunflower. Even Chennai also you see the patient those who came from the Bangladesh, they had nice. But the tenon one is really the new breakthrough.
Really helped a lot.
Help a lot when the tissue is concept of the tissue, specifically COVID time, whenever that there is a zero collection of tissue for the COVID, even also no your glycerin tissue also not available.
Actually, I'm working in the medical college, so my patients are very poor. So before COVID, I have never done tenons patch grafting, because in COVID, and I'm IBank in charge also, so I have plenty of cornea, no issue with that. So in COVID time, I started tenons patch
COVID
grafting.
actually gives us a new breakthrough that we can do it, even the tissue is not there available. That's a nice presentation, ma'am.
Thank you.
Excellent, very good. Thank you so much. Thank you all.